I would like to talk about the importance of GIPS, Global Increased Permeability Syndrome. Because if water is the problem, then deresuscitation may be a solution. I have to disclose a member of the Medical Advisory Board of Göttingen, and on the next slide you can see my other disclosures. I would like special thanks for Jolt Molnar and Louis Forney for sharing some of their ideas, and my biggest bias being the co-founder. Good day, ladies and gentlemen. Today I would like to talk about the importance of GIPS, Global Increased Permeability Syndrome. Because if water is the problem, then deresuscitation may be a solution. I have to disclose a member of the Medical Advisory Board of Göttingen, and on the next slide you can see my other disclosures. I would like special thanks for Jolt Molnar and Louis Forney for sharing some of their ideas, and my biggest bias being the co-founder of the World Society on the Abdominal Compartment Syndrome, now known as the Abdominal Compartment Society. So after a brief introduction, I will take you to the what, the why, the when, and the how when it comes to GIPS. My talk will also be about breaking some bad habits. Recently, some data came out on the knowledge of the 4 phases of fluid therapy. And about the same time, 2 papers came out, and soon another paradigm-changing review paper will be published in Elders of Intensive Care. When it comes to social media, there is a slight preference for the acronym ROSE over SOSD. And I would like to present to you the ROSE: resuscitation, optimization, organ support, and then the stabilization, some point de-escalation and evacuation, or thus the deresuscitation of our patient. Hence the ROSE acronym. So after the first hit, fluid balance should be positive and we can save lives. Then we need to optimize, stabilize, and then finally evacuate, of course, avoiding hypoperfusion. Hence the ROSE acronym. So I must tell you, ladies and gentlemen, that the blossoming of the rose and the drying of the rose at the end is just a dry rose, not a dead one. So what are we talking about today? So let's get to the definitions of fluid balance and fluid overload, which is defined as a cutoff value of 10% of fluid accumulation, as this is associated with worse outcomes. So early adequate goal-directed fluid management is on average 30 mL per kilo, and as the SEPSIS campaign guideline subscribes within the first 3 to 4 hours for everyone. Late conservative fluid management is 2 consecutive days of negative fluid balance within the first week of ICU stay, and a late goal-directed fluid removal is active removal by diuretics or renal replacement therapy with ultrafiltration, and this is known as deresuscitation. So what is this global increased permeability syndrome? Well, it's a combination of a persistent positive cumulative fluid balance together with new onset organ failure. So it's characterized by the absence of transgression from ebb to flow phase of shock, as we will show on later. So let's get back to this 30 ml per kilo in 3 hours, because this will result in anasarcodema. And I'm sincerely convinced that this is not of domestic concern, because you can literally drown a patient with 30 ml per kilo of fluid. Because a positive fluid balance is an independent prognostic factor in patients with sepsis, and should favor restrictive fluid management. The reason being is that fluid overload is related to end organ dysfunction and failure, eventually leading to the global increased permeability syndrome. So when should we worry? So after the first hit, regardless whether it's trauma or burns or surgery or sepsis, the patient will enter the ebb phase of shock. So we will give infusions, and this will result in ischemia reperfusion. So the second hit merely is the reaction of the body on the treatment that we provide. And then a whole lot of things happen, good and bad, oxidants, antioxidants, pro and anti-inflammation, ischemia reperfusion, and DEMS and PEMS, as we will tell later on. This is why exactly in the Sepsis 3.0 new definition states that sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection. First author Mervyn would say that sepsis indeed is bad infection. Brings us to the third hit in GIPS. So let's go back to this ebb and flow phase of shock. So after the first insult, there is a systemic inflammatory response, increased capillary permeability, organ dysfunction. So ischemia, reperfusion, and fluid overload is the second hit. In fact, fluid accumulation is a biomarker for critical illness. And most of the patients reverse shock, but there's good source control, proper antibiotics, good surgery, but some of them will stay in a state of unresolved shock with a positive fluid balance, and they may need the resuscitation. And this is what we refer to as the global increased permeability syndrome. So, GIPS is a positive cumulative fluid balance with organ failure. As we can look at increased abdominal pressure, a low PF ratio, high extravascular lung load or PVPI. We believe that the gut plays an important, essential, key role. Because after the insult, when there is inflammation and increased permeability, there will be ascites and increased abdominal pressure, and maybe abdominal compartment syndrome. When this fluid stays on board, it will further enhance inflammation and permeability, leading to more second and third space fluid accumulation. And I would refer to this as toxic lymph, toxic ascites, and toxic interstitial edema. Why toxic? Because the fluids are rich in cytokines and they will further enhance inflammation and permeability. So if we leave all these toxic fluids on board, this will eventually result in distant organ injury, as we know, AKI, lung injury, ARDS, and multiple organ dysfunction syndrome. So, what if I told you that the gut is the motor of multiple organ failure, and ACS could be the ARDS of the gut? So we tried to drop a new term like AIDS, acute intestinal distress syndrome, but the problem was that I got invited to HIV meetings. So let's go back to these DAMPs, the disease and the damage associated molecular patterns, like this guy who is suffering multiple hits. So it's the combination of this first hit, the second hit, the third hit that will eventually, in combination with the pathogen associated molecular patterns, so lead to a pattern recognition receptor expression that will then produce and incite the inflammatory cascade and trigger the cytokine storm. But what if I told you that treating sepsis is more than just the bug alone? And you know from the movie The Matrix that Morpheus presents to Neo two pills, a blue pill and a red pill, and Neo is hesitating, but finally he takes the red pill. So by taking this red pill, Neo stops believing that sepsis is just about treating the bug alone by giving antibiotics. So by taking the red pill, Neo enters the matrix and he realizes that sepsis is more than just PAMS, but also DAMPs. It's the reaction of the body on the primary insult, which incites a cytokine storm. And Neo understands that with the proper treatment and taking into account, the patient can be saved. So when I got to my room rest yesterday, I just lay on the bed. I was gonna take a 50-minute nap. But when I woke up, it was 50 minutes before this talk. So in fact, what in my perception was 50 minutes was more than 18 hours. You've been watching this blue screen for a couple of seconds because I want you to experience time as it is an issue. It's the essence, because time is tissue. This is a healthy capillary, and this is the same capillary when it's gone leaky only 5 minutes after the insult. So it's like a leaky bucket, and the fluid that we give will leak out, and this fluid rich in cytokine will create a cytokine storm. And if we don't do anything about it, it will increase death of our patient. So it's when the body becomes its own enemy. So by avoiding GIPS, we may help to regain control. So a capillary can become leaky not only very fast, but also at a distance. You're now looking at a hamster cheek pouch with fluorescent labeled capillaries after 10 and 30 seconds of an insult into the peritoneum. So it occurs rapidly and it occurs at a distance. So how should we deal with GIPS? Well, if we look at the literature, there's not much publications on GIPS. But I would like to present you some solutions, at least if we individualize and personalize the care of our patients, taking into account the DAMPs and PAMPs. Each patient is unique. So maybe we could identify a patient needing special adjuvant treatment based on endotoxin activity assay. Or maybe procalcitonin could be useful. Indeed, when there's a non-responder, the patient may be too ill for adjuvant treatment. Or the patients may have a natural cause and heal themselves. So it's to identify those patients where adjuvant treatment may be helpful, for instance by cytokine removal. Maybe it's the inflammatory response that's different. Indeed, some patients have very high IL-6 or IL-10, and this is related to a hazard ratio of 20 with mortality. Maybe there is genetic polymorphism. So I can tell you, if you were thinking that I was going to tell you the holy grail, you can stop holding your breath, because there is no cure for sepsis. And it's definitely not vitamin C. Also, it's disappointing that extracorporeal techniques or cytokine removal techniques, it cannot be advocated at present time because we need more data for randomized trials. So it's all about setting our targets right in order to reach our goals, which is to avoid GIPS. So every patient needs unique treatment. So we must at least assess fluid overload, maybe looking at other parameters, like the urine albumin over creatinine ratio, or by using bioelectrical impedance vector analysis, or looking at extravascular lung water or the capillary leak index, which is the serum CRP divided by the serum albumin, or maybe pulmonary vascular permeability index with transpulmonary return dilution. Or why not identify the patient who is at risk for GIPS by a furosemide stress test? And once identified, we could apply PAL treatment, PEEP, albumin, Lasix to evacuate the excess fluids. So, I would like to extend a kind invitation to join us for the next International Fluid Academy Day in Amsterdam, the end of November, and you cannot wait. Please join us in Dubai for a mini IFAD. So let's come to our conclusions. The known knowns is that we know that septic shock and GIPS is very complex. The known unknowns, well, we don't know who to treat, when to treat, how to treat. The unknown knowns, well, we don't have a clue. But I believe that we should avoid fluid overload and consider a possible benefit for late conservative fluid management or late goal-directed fluid removal. The unknown unknowns, that's what research is for. And I thank Louis Forney for giving me this idea for my conclusion slide. Thank you for your attention.